At the outset,
Actually,
I
we have
must
already
thank
finished on time, but
I must thank All
yeah,
India Ophthalmic
yeah.
Society for giving me this opportunity. Thank you, Dr. Lalit, and all the panelists. So I'll be talking on how to manage CSR, my experience of over 10 years. These are the financial disclosures, and I think all of you know that acute CSR we must observe patiently for about 6 to 8 weeks. We don't want to intervene. We definitely want to make sure that steroids are removed from the usage by the patient, reduce stress, and stop smoking. When you have chronic CSR, which could be either a non-resolving CSR, a recurrent CSR, or a chronic CSR or an inactive CSR. Now, for these cases, a lot of systemic medications have been tried. Thermal laser has been given for extra foveal leaks. PDT has been done, but the dye is not available, and the micropulse laser. So there are numerous systemic medications which have been tried. I don't use most of them. The only thing which we may use is carbonic anhydrase inhibitors, antioxidants, and sometimes, very rarely, epinephrine. I am not fond of using epinephrine at all, except when there is a inferior detachment in case of CSR, when I may use epinephrine. My go-to methodology is micropulse laser. So I don't want to use all these medications because it can cause a lot of systemic problems, the medication itself. So for me, PDT is out because dye is not available, and of course these systemic things is off. And for me, the go-to method is a micropulse laser. So what is the treatment protocol for the subthreshold micropulse laser? I don't use it in acute CSR except patients who are symptomatic and do not wish to wait for 3 months. There we have used in some cases. We used only in cases of chronic CSR. A micropulse laser is not same as a subthreshold laser. This part you must remember, because micropulse laser, the pulses are electronically divided to make it into micropulse, and this is what it is. If it is a 5% duty cycle, that means if, for the 2 millisecond laser, it's divided into the gap is about 1900 microseconds, which is no activity, and about 100 microseconds where activity is there. So that is what micropulse laser is all about. And people invariably said, what is micropulse laser doing? I can't see anything. So there was a beautiful experiment done in Japan on immunohistochemistry where they showed that micropulse laser, you will see here the micropulse laser getting activated, and you can see the ring being forming. This is for the heat shock protein. Now we have an internationally, we formed a group which is a subthreshold laser group, which has said that the parameters are that you do a test spot in a micropulse mode and then bring it down to 50%. There also you have to titrate it. Like for CSR, I follow a percentage between 35 to 45 percentage. And these are the various methods of titrating. What I do is that I do a test burn in the micropulse mode, and then I reduce and this is done nasal to the disc, and then we reduce the burn, the percentage, and bring it down to about 35 to 40% of the micropulse laser burn. So this is a series of about 42 eyes, which included 7 females. 29 were unilateral. There were 3 males which were bilateral. I will just show you the examples, not go into many of these details, but 90% of them responded by 3 months, and rest of the cases did need a second treatment for them to respond, and most of the cases have responded. So these are some of the acute cases where we have done and the patient have responded. This was a series of 15 eyes we did in acute CSCR, and all of them responded with micropulse laser. That these were just a small study that was done. I do not recommend micropulse laser in acute CSCR. So this is various cases of chronic CSR I'll be showing you. So this was a patient who was a laparoscopic surgeon who had been treated with apnea, had been treated with thermal laser, had been treated with TTT, and he came to me with CSCR. He was 6'6", but had recurrent episodes with metamorphopsia. So this is, I've been following up for last almost now 5 years. He has had multiple episodes and he is doing well with subthreshold micropulse laser. And he asked me, why was I not referred to you earlier when a micropulse laser? So this is what I'm saying. You must give them the option and find out who is doing micropulse laser, because patient may start asking you this question. This is another patient of chronic CSR treated with micropulse laser, did well. And this was a dentist. For 5 years he had had a chronic CSR. His complaint was basically against was metamorphopsia. And we did an octave with this patient, and we found that in the right eye he had he had a macular neovascularization, which was like IPCV. So whenever we do a patient with micropulse laser, we do an octave before to rule out a choroidal neovascular membrane, treat it with an intravitreal injection of aflibercept in these cases, and only then, whenever we are sure that there is no membrane present or that it is quiescent, then we go ahead and do micropulse laser in this patient. So this patient was treated for both eyes micropulse laser. I'll give you the example. So the right eye was treated with ILIA, and 1 month post ILIA he received micropulse laser treatment. So in the left eye, after treatment within a week, actually the central thickness may increase. Patient did not, so we follow up on a sequential manner. Patient was not symptomatic, but I found that the central thickness had increased, but over a period of month, the central thickness was brought down and it was 6'6". This is an ophthalmologist resident. During his residency, he came to me repeatedly during 3 years and was treated with micropulse laser, and after his residency is over, his stress has gone and he is doing well. So this is about micropulse laser. We have had an opportunity of treating a patient with CSCR in pregnancy. So one way was to wait, but the patient did not wish to wait. So we went ahead and treated with micropulse laser, and the patient responded well. This is the octa and the same patient. Patient did well. So in conclusion, workup of a patient for subthreshold micropulse laser, we do an autofluorescence, we do a colored fundus photography. You can see the tracks of CSCR in these cases, and this represents that it was an old CSR and we do an OCT and then see if there's a neurosensory detachment. We do a test burn, and after doing the test burn, we go ahead and treat the macular area. So in conclusion, take-home messages: subthreshold micropulse laser works in CSCR consistently. Chronic CSR may need this may need to be repeated. You must titrate in every case. There is no standard power which is used in cases. And I titrate after doing a test burn. I bring it down to about 35 to 45%. And apnea can be used in certain cases, but a micropulse laser does give you a good results. Thank you very much.
Thank you, Ajay, for elaborating usage of micropulse, I think which is underused, as I would say. Do we have Isha Acharya?
Dr. Aurora, can you use this machine for some other purposes also?
Yeah. So micropulse laser I use for routine laser. I use micropulse laser in venous occlusions, micropulse laser in diabetic retinopathy. In all these cases we have done, and I have recently used in cases where a patient of AMD is not responding to anti-VEGF. This is a recent thing that you treat them with micropulse laser and they start responding back to an anti-VEGF.
And you have a separate green laser separately and this separately. You have two machines?
No, the same machine. You have a micropulse mode. Basically, you have a scanning laser, so you should have the multi-spot this thing, because you multi-spot spots are given. The spot distance, there is 0 spot distance, so that's how it works.